Oh, I'm Ron Bergman. I'm a generalist OBGYN practicing in Springfield, Massachusetts at Bay State Medical Center, and I'm also a professor of obstetrics and gynecology at Tufts University School of Medicine. I am here with Bob Barbieri, who, as you well know, is the editor-in-chief of OBG Management, also is the chair of obstetrics and gynecology at Brigham and Women's Hospital, Boston, and the Kate Macy Ladd Professor of Obstetrics, Gynecology, and Reproductive Biology at the Harvard Medical School. And this issue of OBG Management will have a number of articles I think that will be of great interest to our readers, and in particular an article by Dr. Amanda Fader, who is the director of the Kelly Gynecologic Oncology Service at Johns Hopkins, and her article is on tissue extraction at minimally invasive surgery. Certainly a controversial subject, and I think subject that's actually dealt with very nicely by Dr. Fader. Maybe, Bob, you have a few comments to make on this article.
Thank you, Ron. As our readers huddle under their blankets waiting for spring and much warmer weather, I would recommend to them that they read Dr. Fader's article on the evolution of tissue extraction during minimally invasive gynecologic surgery. Dr. Fader, I think, provides a very good overview of how quickly our approach to tissue extraction has evolved over the past 12 months. She focuses that most gynecologists are currently using one of three approaches to tissue extraction at minimally invasive surgery. One is that some people are continuing to use open morcellation with careful selection of low-risk patients prior to performing the morcellation procedure. Two, she at her own institution uses scalpel morcellation within a containment system or a bag. In addition, morcellation at Johns Hopkins is done under IRB supervision. And thirdly, at some institutions, all intraperitoneal open power morcellation of uterine tissue has been banned. I think we've come a long way since the widespread use of open intraperitoneal morcellation prior to 2014. Dr. Fader then goes into a discussion of the importance of weighing the benefits and risks of various approaches to tissue extraction. I think she correctly points out that there is no prescription medicine or surgical procedure that is totally free of all risks. As clinicians, we're constantly balancing the benefits and risks. She points out that a commonly used medication, tamoxifen, doubles the risk of uterine sarcoma, but the FDA has not banned that medication from being used. Dr. Fader believes that there should be careful selection of patients who are going to undergo tissue extraction using an open morcellation approach, and she especially focuses on the higher risk of an occult leiomyosarcoma and uterine tumors thought to be fibroids in women who are postmenopausal and with increasing age. I think recent data has clearly pointed out that for women under age 40 who in a thorough What's happening at your institution with regards to the approach to tissue extraction and minimally invasive surgery?
Well, clearly open morcellation is not being done very extensively in the past. Some people are trying, obviously, to use the various bag approaches, but clearly we do not have set up a system at this point in time as comprehensive as Johns Hopkins does, and thus I think people are going more to either less minimally invasive surgery, particularly for, let's say, fibroid uteruses, which at times would have been taken out via minimally invasive approaches, or actually relying perhaps more on vaginal hysterectomy when obviously the surgeon feels comfortable in doing it. I mean, the take-home message I get from this also is that patients who are undergoing this type of surgery where you're thinking about using tissue extraction must be thoroughly evaluated. And some things that may not be done routinely. I mean, endometrial biopsy clearly is important, and she points out that, in fact, a significant proportion of sarcomas can be, in fact, diagnosed via endometrial biopsy, and she does cite a study where a fairly high percentage, in fact, were. Also, use of MRI imaging, obviously, where one has a myomatous type uterus to see if there's anything that would suggest a sarcoma. And then the use of very comprehensive history, looking for risk factors such as BRCA or HNPCC mutations, atypical fibroid history, pelvic radiation in the past, which would increase the risk of sarcomas and the like. But the other area that's challenging, I think, for practitioners, they also require a peer-reviewed preoperative conference on all of these patients. Now, that may be part of their IRB requirement, but they feel that all these cases need to be peer-reviewed in advance before one proceeds with the surgery. So it's very clear that they're taking a very cautious approach, but I think it's like anything in medicine. There is this pendulum swing. For a while, we just sort of did them. Yes, we counseled patients, but we're probably less aware that some of these occult tumors could occur. Now we're in a sort of a phase where everyone is avoiding extraction or trying to think of some other approach to it, and I think at some point we'll level off somewhere in the middle.
That's a great perspective. It'll be very interesting over the next year to see how this develops and if new technology is introduced to help increase the efficiency and safety of tissue extraction and simultaneously minimizing the risk of spreading small bits of tissue or cellular material around the peritoneal cavity.
I think that's important for us to do. I was just listening to public radio today, and apparently a major insurer is now mandating that you get pre-approval on all hysterectomies other than vaginal hysterectomies. Now, they cite cost, but they also cite some concerns for safety with certain types of minimally invasive surgery, i.e. open extraction techniques, obviously. So again, I think it's up to us to demonstrate that we can come up with a technology that will allow us to overcome these hurdles and to obviously do the surgery safely in individuals. Because I think minimally invasive surgery, as she also highlights in her article, certainly is far better for the vast majority of patients in terms of the recovery. And I think it's important that we not abandon some of the advances that we've had.
I agree with you wholeheartedly that minimally invasive approaches to surgery have really advanced women's health care, and we don't want to retreat to a time when surgical procedures had to be performed with a large laparotomy incision.
Our article actually was your editorial this month of all things cesarean section of very frequently performed surgery. Some would say perhaps too frequently performed in some instances. But I think the interesting part about this article was discussion of how you do the actual uterine incision and how you either make it as well as close it. Maybe you'd like to make a couple more comments about your editorial, Bob.
I was triggered in part to write this editorial because when I trained, we were routinely urged to always perform a bladder flap and close the bladder flap, to enter the uterus gently but sharply with the scalpel
our place. I think the one area where sometimes it's difficult, you may want to do at least a little more sharp dissection is where you may have a low-lying placenta or something of that sort. You're trying to decide where the placenta is as opposed to the uterine cavity. The sort of blunt opening or extending the incision, I think, is widely used in our place. The only area or time that I think I would think about avoiding it is someone who's had multiple cesarean sections and it's paper thin, because I think when you extend it bluntly, you probably have a greater risk, I think, of extending the incision to the areas you prefer not extending it to. You can certainly enter the uterine cavity bluntly, but I think extending it to the side with scissors allows you hopefully to find better tissue that you can approximate rather than perhaps doing it bluntly. But again, as you also point out, there's not a lot of randomized trials that would clearly strongly support one versus the other, so it does look like some of the more blunt incisions and finger entries probably do reduce morbidity to some extent.
I'm impressed that medical practice continues to evolve rapidly. Tissue extraction in minimally invasive surgery has undergone a dramatic reconsideration and change for many surgeons. And similarly, although it occurs over a longer time span, I think we've really seen over at least the past 100 years a big change in how cesarean delivery is performed. And I'm very happy to see this intensified focus on which interventions in cesarean delivery or which practices related to cesarean delivery offer the best outcomes for patients. As an example, the transition in the past decade from giving antibiotics after clamping the umbilical cord to now almost all obstetricians give the antibiotics before placing the initial skin incision, and that probably has helped to reduce the rate of infection post-cesarean delivery.
I think, again, a lot of this change is focused appropriately on safety, and you're right. I think we're in a time of always having change in medicine, but I think we probably are in an era where much of this change is very rapid. And I think certainly it behooves people to obviously read articles that will enhance or improve their practice of medicine, such as these that we've viewed here in OBG management. And obviously you got to keep up, and that's sometimes challenging, but I think it's important if you want to have the best outcomes for your patients. So I enjoyed this opportunity to talk with you, Bob. I'm sure when next time we talk, there'll be equally very interesting articles for us to focus our attention on.
Thank you, Ron. I hope you enjoy the onset of a warm spring.
We should have in the next few weeks. We will see.